Well, I'll call you in a little while.
Okay.
Okay, good. Let's see what the quorum is so far. We're really picking up steam here. It looks like getting towards it. David, just wanted to say hello to you and thank you for helping us out today. Okay.
Not
And
a problem. Thank you very much for letting me participate.
okay, so as you know, this is again the gathering of the jurisdictional medical directors from the large cities here in the United States and Europe and down south and down under and elsewhere. And again, the usual caveats is that this does go public, so please keep in mind that things that you'll say will be out there in the public domain. So be careful about language or any political issues, et cetera. Just as a fair warning. Okay. And then let's see. I'm going to wait just a couple more minutes to let some other people gather. I'm just waiting to see the numbers starting to go up. Hey, Sandy Schneider. I just didn't know if you got a second later. I'll ask you to maybe make an announcement about the changes there at the ACEP in terms of leadership, et cetera. And if that's not putting you in a bad position, that'd be great. Unless it's too premature to talk about that. Okay.
Fine.
Okay.
I could do it now if you want while people are gathering.
Yeah. Okay. Good. Yeah. Please go ahead then. So,
So this has been well known.
Yeah. I just wanted to announce who you are. So Dr. Sandra Schneider, of course, is the Associate Executive Director at the American College of Emergency Physicians, and has been our great liaison not only to the Eagles but also to the federal government on behalf of emergency medicine. Okay, go ahead, Sandy. Take it away.
Right, I'll make it real short. As many of you know, Dean Wilkerson has been the CEO of ACEP for the last 16 years. Marvelous job, really moved the college forward. But he announced a couple of years ago he was intending to retire. Our new executive director is Sue, oh my goodness, Sidori, from, I almost forgot her name. She has been the executive director for the Interventional Radiology Group. She comes extremely highly recommended. We're very, very excited with her. Obviously, she has, she's going to need to get up to speed on emergency medicine, but I think she will bring a great next step in leadership in ACEP.
Sounds like that during the recruitment process, a lot of people were involved and just uniformly just liked her almost immediately. So that's fantastic. Good news. All right. So with that, we're going to probably do a lot of round robin today with various people, but I do want to see, I'm trying to see if we got anybody from overseas piping in yet, because I like to always give them a head start on things in case they have to get off because of the timing. All right. So I think the first thing I want to do is that, Amal, if you don't mind, I'm going to have you come on, who's our Amal Matu, if you don't know, is our cardiology, in-house cardiology specialist, and is basically going to give a sort of a quick update. Not a lot of major things going on, but just to keep you abreast of what's going on in that world, especially related to COVID. But again, you're always welcome to tell us anything about any aspects of cardiology you want during that period of time. Thanks very much. And now, from the great state of Maryland, welcome to our state, Amal Matu. Go ahead, Amal.
Thanks, Paul. So can you hear me okay?
Yes.
So just a little update on the Kawasaki-like syndrome that we talked about last week. Apparently after we discussed it, cases started popping up everywhere. It's been on the national news and all of the networks, this Kawasaki-like illness. And they're referring to it on the news for the most part as what they call pediatric multi-system inflammatory syndrome. And essentially it's, in many ways, it has the characteristics of Kawasaki, but there appears to be a much greater level of carditis involved. And so more of these patients than normal Kawasaki are tending to present in shock or develop shock. And it's very unusual, obviously, since these are relatively young kids for whom we really didn't worry that much at all about COVID during the first couple of months. The vast majority end up recovering, fortunately, but there have been occasional deaths. Other people have also said that many of the symptoms may resemble toxic shock with abdominal pain, nausea, vomiting, and again, of course, shock. And fortunately, most of them are recovering. So people are still trying to get their handle on what is causing this, but there definitely seems to be this association with COVID-19, and it fits in with what we've seen in many other organ systems, in that there's just this tremendous inflammatory response to the COVID-19. And then in terms of other literature, just a couple of points. The FDA recently issued an advisory regarding hydroxychloroquine. In terms of the prolonged QT, there have been more deaths associated with people who are prophylactically using hydroxychloroquine, and in particular, when it is combined with any other medications that can prolong QT, for example, azithromycin, which is how it was originally touted to combine the use. And that's a disaster because both of them together will really prolong the QT and produce torsade. And then the one other thing that's popped up in the cardiology literature is this suggestion of routinely starting patients on anticoagulants because of the high propensity for the development of venous thromboemboli. And there's a couple of studies that I've seen now on starting these patients on anticoagulation. They're very preliminary, very observational, very retrospective. And so there's not a lot of conclusions that can be made from those studies. One of them was a research letter that was just published in Journal of American College of Cardiology. And in that study, they started patients on anticoagulation for the most part who were intubated, and they found that intubated patients that were started on anticoagulation had a longer survival, 21 days versus I think 14 days on average. And again, it's very preliminary, and so I think at most it's just going to be promoting further studies on whether we should be routinely starting patients on anticoagulation. And some people have gone so far as to suggest just start them, anyone who's sick enough to be admitted, start them on anticoagulation, but that's way, way too early. But we'll see how future studies pan out, but just to keep an eye on that.
Right, and there's been, if you don't mind me piping in here, I actually just finished writing a paper with some of our folks down in South Florida. And one of the things we were observing was that there were people that were not only hypercoagulable. If you look at what we did was we looked at TEGs. The first thing that tripped us was looking at D-dimers and CRPs and all those kinds of issues, but those could have been associated just with the generalized inflammatory syndrome. But interesting thing, since we were in a trauma center, we could look at the TEG and we actually saw patterns, and most of the people were hypercoagulable, even without signs at the time of any kind of bleeding or clotting this diathesis. But the caution here is that we actually did find people who actually had hypocoagulability. So I think it has to be checked out. And I hope that in these situations, they were looking at some parameters at the very least to see if people were in fact in a hypercoagulable state and so on. In some countries, they've actually looked at sending people home on low molecular weight heparin. And so that's all out there. But again, the caution is just make sure we double check that they aren't the opposite of what we're thinking under these circumstances. So
Definitely, yeah.
Yeah. Okay, good. And then going back to the thing about the Kawasaki's like syndrome, it is a little different, but it is interesting. It's almost like it's a combination of that generalized inflammatory thing. And then the concern has been the number of cardiac arrests in kids, which is just phenomenal. And I think in those situations, I don't know if it will be interesting to find out if they ended up being, either myocarditis or something like that, or actually a coronary artery disease like you get in Kawasaki's. But you don't have any inclination of that yet. We don't have the data yet on that.
No, not yet. I think they've seen a few coronary artery aneurysms, but probably a little bit less than what you would expect with Kawasaki. And then on the other hand, they've seen more carditis than what typically is seen with Kawasaki. Now, I mean, both of those are part of Kawasaki, but it seems to be more of a myocarditis picture and a little bit less of an aneurysmal type of picture. And that all relates, of course, to the inflammatory issues.
So the issue is not to say that it's a Kawasaki's, but it's something like that, so people will know to recognize all those various symptoms that are similar. That's the main thing in the kids. So
Exactly.
thank you so much.
Amal, the AHA guidelines came out yesterday with COVID all over them, and sounds like they want people checked in the ED, et cetera, before activating the cath lab. Any other conclusions on this update from AHA?
No, that's pretty much in line with the consensus statement that got published a couple of weeks ago from ACC and ACEP and the Society for Cardiovascular Interventions. They would like patients to be reevaluated and risk stratified a bit more in the ED. But for the most part, that entire consensus statement, I think, can be summarized by saying do everything the way we've always been doing. Just make sure that everybody is PPE'd, if that's a verb, properly. And everybody has to take proper precautions. Assume everybody has potential COVID, but go ahead and care for patients the way we always have been doing before.
Thank you. And listen, thanks very much for joining in with us. Okay. And
Yeah, I'm honored.
happy Mother's Day to your bride. Okay. So if you don't mind, hope you
Thanks.
can hang with us for a while.
Yeah, definitely.
Some interesting things here. Hey, so next, I want to just, in terms of just sort of various parameters around here, Peter, can you talk us, I know I was looking for Mike Levy, and maybe I'll wait till he gets on because he probably will join us later. Would you be prepared to talk about some of the platforms that we have there in terms of apps in the era of COVID-19, such as like that Apple PulseOx and maybe the Good Sam platform? Because we heard about Pulsara before as well, right?
Yeah.
Just prepare for that. I'm going to wait. Mike's on now, so I'll give him a fair warning. One of the things that I do want to check in with a few people before I go to that, but Mike Levy, just so you know, I was thinking about, since you turned us on first to the Good Sam platform, since we talked about Pulsara, we thought maybe you guys can pitch in and give a little filler in on, update on those things and maybe even how they're working out so far. I'd like to do that. One other thing I'd like to mention before we go on any further is that I am going to try to talk a little bit about us getting prepared for the future. We have always been ahead of the curve in this call, as you've heard, time and time again. And but I want to be several months ahead of the time because with the latest reports we've got that this is going to be contracted for a while, I want us to be thinking about that if tax dollars are going down, revenue taxes are going down, it's going to affect the public sector, and that means it's going to affect our jobs, as I talked about before. We may have to think about like loss of personnel, maybe a thing to go, or other kinds of resources, and we got to do that. Secondly, I want to make sure that we are ready to vaccinate. Like, for example, 20 years ago when we were talking about this, people like Sandy Schneider and Jim Augustine and those here in the room, and also John Jew, when the era of 911 happened, there was a concern that it was anthrax was out there, that maybe people would use smallpox as a sort of an attack agent, and so we had to be prepared to actually vaccinate people against smallpox. So one of the things we thought we could do is, as medical directors, we could deputize various personnel, not only just the paramedics, maybe even first responders, firefighters, who are under our watch, to be able to deliver those things, under the supervision, say, of health providers. But I wanted us to be thinking about and maybe even prepare for that kind of inevitability, and we can help get vaccinations done faster if we prepared our forces to do that. And then that also leads into the concept, and I want to maybe talk to Peter about this later, about blood draws for antibodies. Can paramedics do it? Because that's something else we could do within our communities, and so on. And then one of the other things that Craig Manifold asked me to bring up is that if we're right now okay for us to do alternative destinations, is that going to go into the future as well? So those are just things to be thinking about, and then we'll talk about those later in more of a round robin discussion of that. First, though, I want to go over to Jim Augustine, if you don't mind, and give us reports from the firefighters side, International Association of Fire Chiefs and Firefighters, and then also, if you don't mind, give us any kind of updates you may have for us on from the Eagles websites. Okay.
Yes, thanks, Paul, and thanks everyone. Paul, you covered a couple of them for the IAFC, and that is big budget concerns, and already some departments being asked to lay people off in the middle of a time when we're really concerned about what the fall may bring. This has been particularly hard on small and volunteer agencies, which is not necessarily where the Eagles manage, but a number of your suburban departments, and the concern that the big agencies will be asked to assimilate or cover for smaller agencies. The IFC has convened an economic task force to help departments manage this, and then to try to come up with ways to use any of the grant funds that are coming through and the other rescue funds that are coming through. At the state level, Georgia, we just had a call. The state agencies are looking at vaccination programs. All of you should be very active in your state looking at setting up the framework to do vaccine programs if they're needed, particularly for persons who are hard to get at in your communities, generally underserved areas. There's a real issue. The PPE machinery has not turned on in this country as yet. That's a real issue. And the FDA this week just, how do I say it? They just took a number of the Chinese N95s out of their approval list. So they have begun to shut down the borders. They're confiscating more PPE there. They are forbidding some of it from moving through. And some states that I'm familiar with were thinking that that was going to be the supply chain, and it is not. And so you should be aware that the PPE machinery has not been turned on in this country yet, and we really need it to be in place if we're to be ready for the fall. Thank you all for your response on the surveys. It's incredible. And the surveys this week had to do with proning, and most of you are not proning yet. And then our ability to do other things in the EMS arena. And many of you are turning on those mechanisms to do those even in your departments. And then we've got the really important cardiac arrest thing that we'll talk about later. So Paul, thank you.
Yeah, no, thank you. Hey, can you tell them whose uniform you're wearing today, so everybody knows where you're hailing from today?
I'm Washington Township, Ohio.
Okay,
in the Dayton area today. Thank you, sir.
It depends on what state you're in that day, right? That's good. And so it looks like you're doing well, and my best to Linda as well, okay? And if you get a chance, let's talk this afternoon. All right, but you mentioned the thing about the cardiac arrest study. I don't see Kevin McVaney on because he's leading that for us, but we are at a point where we actually are prepared to start getting this together. And one of the things we found out was that the replies, that we got through the emails were a little bit, heterogeneous is a good way of putting it, and different was presented. So we think we've got a thing where now that we've got January, February, March, and April behind us, we can look at the data, and we're going to basically request that again, but we're going to do it in a better format. And I'm going to ask both Lauren Maloney and Stein Bronsky maybe to address it. It would be best coming from Kevin, but since he's not on the line right now, I guess I'll turn it over to Lauren, because you've been mostly involved in organizing this, Lauren. So if you don't mind, can you get on? And if you don't know, Lauren's our EMS fellow who's been assigned to us to help us with this project. So, okay, out of Stony Brook. And have I heard the word awesome out of you yet?
Yes, well, it's a good word. So basically what we're trying to do is come up with the simplest possible way to collect the most meaningful data without, wreaking havoc on trying to parse numbers. So what we're going to do is send out a survey that is simple relatively, and also we'll have a piece of paper perhaps that you could give to whoever manages the data for your agency if it's not specifically you. That way it's as seamless and relatively painless as possible.
And one of the things that we found already on the preliminary data is that some cities, especially where they got hit hard with COVID, just jumped with their rates. I mean, very, very much so, where others were trailing behind. Then eventually they started going up as well as time went on. So that's why we want to look at it over the months, and we'll be able to correlate that, we think, with when COVID numbers started going up in your community, relatively speaking. So we'll make some rough correlations that way. And then we're going to ask some questions of you, and we're trying to make it as simple as possible. And I think, Stein, you're creating a survey to ask some of those questions like, is there any perception that you have of what's causing this? Anything you can say, Stein, and how soon we'll have this out?
Yeah, so we finished the survey, building it last night, and I'm actually reviewing it right before this call. We're going to send it out to a select test group within the Eagles.
Oh, nice.
To get feedback. We'll do that today, so that we can get some feedback before we send it out to everybody, which we anticipate will be at the very beginning of next week. And so look forward for that coming.
Yeah. So, anyways, I just as a quick preview of what we think we found, and we'll try to get this published. And everybody participating is going to be named in the publication. We will be asking you what your affiliation is that you want listed, and that means academic as well as, let's say, the city that you're representing, and that. But you'll see all that. It'll be pretty simple, and I really like what they've been doing. So thanks a lot. I want to say a couple things. First of all, Stein Bronsky, as you know, has been our survey guru. He's the medical director for Colorado Springs in that area, and just really appreciate the work that you put into this. Secondly, I wanted to mention Lauren actually has been fantastic, and I found out something about her that not only has she been a paramedic for a long time, but she actually won 2 awards at SAM last year. One was the Research Award, and the other one was the Educator Award, Resident Educator Award. So I just was, we're very, I'm impressed to have her on the team with us. So thank you so much for what you're doing there. Let's see now, let's move on to, next thing is, I'm trying to think who else I wanted to hear from early on, but thank you, Stein, for all the work that you're doing in that area. Okay, so a couple of people that I hadn't heard from for a while, and I'm just gonna go ahead and work on that and just sort of get some reports and see what's happening in their individual cities. Rob Lowe, you're there, right? Can you tell us a little bit what's happening in your neck of the woods, so to speak? Yeah, be prepared.
Yes.
I'm calling on you. Okay, thanks. Go ahead, Rob.
Yeah, thanks.
Here for a while. So what's going on there?
We're kind of status quo here now, as is I think Ohio's kind of bracing for the reopening that we're stepping through. We've seen the same thing with the cardiac arrest. That's baffled us a little bit. We're starting to look a little bit at the child as well, and maybe seeing a few numbers there. And I think, like most folks, just navigating through if we're going to have the stockpiles we need for the second round of this, as far as PPE and staff and those sort of issues.
Okay, and then by the way, so I just want to know, is Grader's ice cream open yet?
Not usually. Not most of them are not.
Yeah. Okay,
a few of them may be on takeout.
So let's see. But listen, so anyway, so Rob's from Columbus, and this is his first year with us. So he's stepping in some big shoes with David Kessick, but just done a great job, and we're really appreciative of you being with us, man. By the way, Jim Augustine was just announcing to everybody that the state of Georgia just reported that the cardiac arrest in the state for the month was up by 25%. So we have a preview, probably what we're going to hear from Lakshmi, and that's even though their EMS transports overall were down 18%, and the motor vehicle wrecks were down 55%. So Lakshmi, anything that you can report from the Atlanta area specifically? Are you seeing the same thing in the city, or even more so?
So I haven't seen a huge blip in the cardiac arrest, not as high as 25% for sure.
Oop, we lost you for a second. Maybe they put a gag order on her. Who knows? Sorry, we lost you. Well, anyways, you can report back to us when you come back. So, hey, Mike and Mike Levy, and also Peter Antevi, are you prepared to give us a quick report on some of the new technologies that we can use or apps that we have out there that we can take advantage of, if you don't mind doing that?
Hey, Paul. Yeah, this is Peter. I can show my screen real quick, and just to give everyone just a little update of what. Let me share my screen here. Sorry. Okay.
And just to tell you where we're going, as I announced before, in the past, we looked at platforms where you could actually communicate with patients. One of them was Pulsara. They were really great, and they were helping us out in doing that. And Stein was really terrific to share that with us. And then you could see that on previous reports we've given, and we can give you specific dates. The other one that Mike had turned us on to was that it was another platform was Good Sam, and Peter sort of adapted it in one area. So if you don't mind, give us a report on that, Peter, since you took as usual, the R&D from the rip-off and duplicate from Mike Levy, as we always do.
Yeah, so no, and first of all, we appreciate Stein. We actually are still looking at both at Pulsara, which we think is a great platform. We're now looking at Good Sam. This is just a little demo version that we have going for this past couple of weeks. But essentially, the cool thing about, and Paul, can you see my screen?
I can see your screen. Yep. I don't know if everybody else can, but I can.
Okay.
So I'm sure you can. All right.
Gotcha, Peter.
Okay. The cool thing about Good Sam is that it required no kind of logging in for the patient, and actually it was basically set up within just a couple of minutes. And so I'm gonna do a little demo. I have my son, Jordan, you can walk outside the room. No, okay. So essentially, we've done a couple of these consultations where you go to instant consultation. And again, how this would work is that my dispatcher would create a queue for my community paramedic, who's Sue Tulin, to give them basically the patient's name. My ambulance is on the way to the scene here, right? I would say new consultation, and then essentially I would just put in the number. We'll just do that. We'll just do this real quick and show you that. So now basically what I've done is I've sent the invite to the patient. Now, of course, I've sent it to my own son here, who's right outside my office. So he just got a text. And again, all this is thanks to Mike Levy for showing us this, but my son just got a text. He's just gonna click on the link of the text, and then he will now show up. So Jordan, you clicking on the link, buddy?
I didn't get it yet.
Oh boy. Come here a second.
If you're using a plus, you probably need to do a 1.
Yeah, I gotta put a 1. Yeah, hold on a second. Here, take the phone back. Sorry, that's my fault.
Okay.
The only snag here is that you have to have a 1954.
So that's actually a good learning point. You did that on purpose, I know, right? Just to show everybody. That's cool, Peter.
All right, so here we go. So now he just got a link. So imagine this is the patient who's not gonna be my son. And I can actually be here at home. My lieutenant, I can get my lieutenant kind of roped in as well to this as well. So here you'll see in a second that he'll click the link. Here he comes. Take him out, please. Hey, Jordan, are you the patient?
Yep, I guess so.
You can stop walking. You can stay right where you are, pal. All right. How are you feeling today?
Great.
Okay, it looks like you have a fever.
Yeah,
Okay.
definitely.
So now I could also add in my lieutenant who's outside the door, and we could do a little consultation here. And so the app has many other features, but this is just one of them. So, all right, Jordy, you look pretty good, man. Go take some zinc. I'll call you in the morning.
Yeah, bye.
All right.
Peter, it's AJ. Doesn't the app still have the feature where it can pick up your pulse and respiratory rate?
It does. It does. Right. I wasn't able to show that, but if Jordan put the phone up to him, there's a feature that shows exactly his heart rate and his respiratory rate. So Mike Levy is using this in a much more kind of robust manner than I am, but I just wanted to show the demo. I guess I'll pitch it back off to Mike, and then also just to kind of get his input. But the guy who created this is a UK neurosurgeon who's kind of doing it for the good of the people. It's a nonprofit organization. Pretty cool stuff. And again, with Pulsera, I think that the connectivity is much better. The video quality is much better. You have a lot more features. But I just wanted to show this aspect of it because it was pretty easy. There's no setup on the end of the patient to sign up. They just have to get a text message. And I'll stop there, Paul.
Good.
Hey,
And
Peter,
Mike,
this
can you
is-
tell? No, go ahead. Go ahead.
No, I'm
Who's-
sorry. This is Stein Bronsky. Peter, did you say that when you with Good Sam, when you send the invitation and the patient actually clicks on it, that they initiate the video link, or do you have to go back and then initiate it?
No, the only thing I did there, I typed in my cell phone number, and my son had my phone. He clicks on the link, and then you saw we just both popped up together. So it's as simple as just adding the phone number in there, and you're sitting at a desktop terminal like your community paramedic, and then within kind of instantly. Now I will say we've had some connectivity issues, and it only really works that we've noticed if you have good cellular service or Wi-Fi. So my only knock on this is that the video is not like a great, almost like a FaceTime level video, where I believe that the Pulsera, to my knowledge, gives you just a much better quality. So
Okay, and Mike Levy, can you pipe in on this one and tell us any other perspectives or things we've left out on this presentation?
Peter did a great job of the presentation. Again, the strengths are no cost to the agency. And there's some other things you can do. You can hook up video to it, so you can have a video server so you can record all the instances. And it's really pretty straightforward that way. The other build out from this is that its initial intent, of course, was a crowd sharing app for time sensitive critical emergencies, cardiac arrest. But it's got other cool things like a Z-axis on its GPS, which is kind of novel, I think. So you can actually tell how high up a person is in a structure as opposed to just having an XY axis. Yeah. And it does other things like allowing for declaring an LZ for a drone. So for areas that have the line of sight abilities for drones, usually they require that you have a cleared LZ, landing zone. And so this does that too. I think the real feature is the beauty of it is the fact that no one has to sign up for anything. You push a link, they enable your ability to use the link, and there you go. Right now, we initiated it here in Anchorage and in one of my smaller areas and more remote. And at the same time, our curve has flattened and we're opening up. So right now we're actually not doing pre-screening at this point in time because we've moved back into more normal operations.
Mike,
but I'm still very enthusiastic about
am I right in saying that it is Pulse Point on steroid?
Yeah, you know what? Yeah, Mike, go ahead, and I have a comment on that too.
I think the thing about this is this is a not-for-profit organization set up by Wilson, who really seems to be the embodiment of Buckaroo Banzai. And so he is just this amazing.
By the way, Mike, I get it totally. Great one. Good one. Okay.
No matter where you go, Paul, there you are. But the nice thing about this is that it really is extremely flexible and extremely proactive. So there's a number of changes that have been integrated kind of in real time. And I think that's inspired other systems like Pulse Point to follow that lead and integrate those type of technologies. So it's good.
Yeah.
So can these guys, yes, go ahead.
Just one more quick comment regarding Pulse Point is that with Pulse Point, if my next door neighbor is having a cardiac arrest, I will not get alerted yet, right? I know they're working on that. This platform, Good Sam, is totally managed by the agency so that if I'm a registered person in Good Sam under Coral Springs Fire Department and my next door neighbor is having a cardiac arrest, I will get alerted. So Pulse Point doesn't know who you are or that anyone can join Pulse Point. This is the opposite, where you actually manage who gets on, and therefore you can send anyone to anywhere. And so it's kind of a different model than Pulse Point, but I think it has the same kind of reasons for existing and a lot of cool features.
One of the questions that came up from Tom, and I think you already answered, Tom Collins from Cleveland, is that I want to know if multiple people could get on at the same time, and you already addressed that you could get your officers on or responding medics or whoever, right? So.
Yep.
Yeah. So I just want to make sure everybody know Peter is the chair of the Greater Broward, this is Broward County, Florida, Broward EMS Medical Directors Association, and has been our in-house pediatric person along with some of the others there, Joelle and Meg, and wanted to thank him for always staying on top of these kinds of things and so on. And then Mike, of course, is the medical director for Anchorage and the surrounds. There is a large state up there. And he is also the incoming president of the National Association of EMS Physicians. So he's like, and by the way, Mike, anything you need to report from that end or so we're sort of on top of that one, or what do you think?
Encourage everybody to visit the website, naemsp.org. I know most of us on this call, hopefully all of us on this call, are members of the organization. We're having our next town hall meeting on May 14th, which is going to be critical care issues. It'll be led by Jake Keeperman and two of his colleagues from St. Louis area. Always remember the base camp group discussions that we have within the website itself. We had a town hall last week, I think it was. taking 3 of our state chapter leaders to help further explain how the state chapters have helped the entire state move forward with regard to this situation we find ourselves in. So I would encourage people to reach out to the state chapters, recognize the value therein, and become contributing to that. And last but not least, the fellows applications end in August. So if you're looking to get your FAEMS, be sure to get to the website and apply for that. Thanks.
Okay, good. And then, so just to finish off this issue about the Good Sam, if anybody needs to learn more about it, they could contact either you or Peter, I suspect, right? Or we could send information out to the group via Jim.
I shared that screen real quick, but goodsamapp.org, I think, is the website, and they're very responsive. But if you want direct access, we can certainly give you Mark's phone number. He picks up the phone night and day. I think that's that neurosurgery training thing. That sounds
great. Hey, I don't know, just to prepare you, Kathy Clem, I think you're online with us today. And so I don't know if you'd be able to unmute yourself and get on, but you guys have set up a really good system up at Dartmouth in New Hampshire, and you've done really well in terms of telemedicine, if I remember. Is that operating out of the emergency department or with PCPs, or is it at all linked in with EMS? And then finally, I'll just prepare John Jew. You've been doing it out of the emergency department as well in Portland. Can you tell us a little bit about what's happening there? Because this may actually be, I think, a harbinger of the future for just in general, not just for this particular COVID issue. So Kathy, if you don't, and by the way, if you don't know Kathy Clem, she has been the chair at chief of emergency medicine chair at places like Duke and Loma Linda, and has now become, I think, if I have it right, associate dean up there at Dartmouth, and has been a longstanding, as far as I'm concerned, role model for me in emergency medicine, and glad to have her on board with us today. So go ahead, Kath.
Hey, thanks for inviting me, Paul. I will tell you, I've been at Dartmouth now just since January, and they have a long history of being the telemedicine hub for the whole area. So what that has happened is that role has just expanded. So right now, I'm going to see if I can pull up the stats for us, but this is, we get a report every day. And so right now, and we have both New Hampshire and Vermont that we cover, plus parts of Maine, and actually into some parts of New York where we have an area that we cover. And right now in New Hampshire, there's 2,636 cases, and in Vermont, there's 907. And of those, only 6 are hospitalized at Dartmouth.
Wow.
So that shows you, and 5 of those are in the ICU. The rest we're actually monitoring by sending people home with the pulse ox. I love the idea of your apps because we're actually handing them pulse ox, little machines with batteries that have to be replaced. So I love the idea of the app. So this has been great for me. I'll take that back. And then we arrange either once a day, twice a day, twice a week, whatever the patient needs, telemedicine visits. And I was also very much intrigued with the apps that will also count their pulse and respiration. So we're actually, during our telemedicine, we have a patient put their hand on their chest and we count literally how they breathe by watching their hand go up and down. So we're rudimentary compared to the way.
Oh, we lost you. We just lost your audio, Kath. Sorry about that. Sorry about that. We just lost your audio for some reason. I'm not sure what happened. Well, that's too bad. You didn't by any chance mute yourself by accident, or did everybody get muted here? I don't know. No, you look like you're unmuted. Yeah, I'm sorry then. I'll tell you what, let's see if you can keep trying here. David, any suggestions about that one? Or is it just coming from her end?
It's just coming from her end.
Okay, got it. Well, I tell you, Kathy, keep trying anytime. Oh, here we go. Now we can hear you. Go ahead.
I'll try to get it figured out.
Okay, got it. We got you. Go ahead. No, we could hear you there just now.
Where did you lose me?
No, you're back. You're back. Can you hear me now?
Just shortly.
Yeah. Okay. Good. Okay. Go ahead.
So I don't know where I lost you.
No, you said that you had so many cases you're managing, you liked the apps that we were using, that was helpful. You're going to take those back, et cetera, right? So, okay.
Right.
Especially that, because you said you were having people feel their heart rate or whatever, but that's it.
Their
Okay.
pulse, we watch their respiratory rate. We watch them breathe by having them put their hand on their chest, those kind of
Yeah.
things. And we were looking at the Cardia app that gets advertised on TV for the patients that are on the experimental hydroxychloroquine to see if that's working. We have patients on that. We have several drug trials going that we're monitoring on the outpatient basis as well as inpatient.
Okay, so let me ask you this: what's your interface there with EMS? That's what I wanted to know is how this has been of value to them and how that interacts there.
So we have DART, which is our program that is that circumferential I was describing, going all the way up to Maine and parts of New York, and we have actually seen a decrease in transports. A lot of what we get gets brought into Dartmouth because we are so remote. And it has been a hard time for us, but we do have a good system for our helicopter pilots, and the fact that we are able to put a screen up so that they're not being exposed to COVID patients when they're bringing them in. And our EMS, we've worked hard to systematically get all of them using the same PPE. When we started, some of them weren't even wearing masks, and now they're all wearing N95s and with the hand cleaning, and we're all doing the same thing. So unifying all the different EMS components has been a huge part of what we've been supervising.
Okay, good. And then you guys have developed a really good system there for reusing your mask as well, correct? And do you feel that's an appropriate system and it's worked out for you?
That is one thing I think Dartmouth has done extremely well, and that is, except our gloves, everything we're using is recyclable. So we recycle our N95 masks, we put them into a little food bin, put our name on it, it goes off, gets hydrogen peroxide cleaned and gets returned to us, so I don't have to get somebody else's, I'm assuming it's nobody else's mask anyway.
Yeah, right.
Anyway, so, and then of course the PAPRs can be redone, and then we actually have our respirators that can all be cleaned. So everything is reusable that we're using except for gloves. So we have not had a problem with running out.
Okay, good. All right. Well, listen, thank you very much for the great work you're doing. And many of you have worked with her, and she's been on some of our panels in the past. So wanted to make sure she was plugged in with us and continues to do that. So thank you so much. And great to see you, by the way. So it's good.
Thank you.
And happy Mother's Day to you this weekend on multiple accounts, since you're the mother of many. So. All right, so let's then move on to, I think, taking some reports around the world here. And first of all, Mark Gautreaux, if you don't mind, I'm going to give you a heads up, and then I'll come to Meg next. Just wanted to see what was happening in San Jose, besides the fact that the weather is changing there, right? I think we have a lot of people who've got weather. Like you have snow up there, right, Kathy? Is that what I remember? Is that correct? Yeah. Yeah. Okay. Mark, you want to go ahead?
Yeah, sure. Yeah, it's 88 degrees yesterday and today. So, but it's a dry heat. So
yeah, right. Okay.
Yeah. Countywide and in the two counties that Stanford covers, we continue to dribble downward. I think yesterday we had 18 new cases in Santa Clara County, so kind of low numbers. Interestingly enough, although California has started to relax some of the restrictions, the Bay Area counties have elected not to do that. So we're maintaining all of our restrictions until at least May 30th, which means all the retail stores remain closed and no seating at restaurants or anything like that. In terms of our numbers are starting to trickle upward a little bit in the past week or so. One of the things we've noted is that we've seen an increase in motor vehicle fatalities while a decrease in accidents because the speeds are so high on the freeways here. Yeah.
Interesting.
So,
okay.
Yeah. And we've also seen an increase in house fires. In fact, San Jose, I think, had 2 this morning. And we're not quite clear why that's happening. A lot of people are cooking at home, I think, and setting their kitchens on fire when previously they weren't used to doing that.
And I suspect that alcohol is not involved at all, right?
Not at all involved. Okay, go ahead. But other than that, we have had really no new infections in our first responder community. We elected early on not to require face masks in the fire stations because, number one, we didn't have enough of a supply of face masks to do that. And also we felt that they're working 48-hour shifts, and having them wear face masks for 48 hours was just completely miserable. They go on calls and they clean the station. That's all they do. And we have had no new infections among our workforce, both in the EMS area and also, interestingly enough, an extremely low infection rate in our hospitals.
Yep.
So that's a good thing.
Okay. Well, that's fantastic then.
And hey, Mark,
Yeah.
it was your experience that forced IFF to want to use masks. So you guys kind of dumped on the rest of the jurisdictions around the country, and then you quit using masks. Second thing, it is very well known right now that there will be an increase in arson fires as small businesses and homeowners are facing financial issues. So you should all watch out for those. And then booby traps and other issues that come around arson-driven fires are much more hazardous. So that's something worth all of you being aware of.
Absolutely, and yeah, we have been discussing that. What's interesting is that our experience with that wave of infections that spread through our department, we can actually trace back to the first known death in the United States was in that firefighter's district when he was on duty. So he actually worked that code.
Yeah,
and that's probably where.
So, hey, just to give you a heads up, thank you so much, Roberto Fumagalli. Okay, I just want to prepare you. We're going to line you up next if you can get on. But Mark, thank you so much, and thanks for keeping us ahead of the curve on a lot of this stuff. I appreciate it, and enjoy your weather this weekend, okay? Hey, Professor Fumagalli, are you available to talk to us? Yeah, I see you're online. I don't know if you've got to unmute yourself here, if you can. If not, yeah, there you go. So welcome. Thank you very much. So just make sure you understand on the line now is our Eagle from Milano. And Professor Fumagalli is the head not only the ICU and the emergency department, but also the regional rescue system and ambulance system. And you know, they got hit hard, and it was the busiest metropolitan area up until New York to get hit with this. And so can you give us a report? You guys sort of relaxed things out there in Italy a little while ago. What's happening? Are you having a resurgence or anything new there?
I'd say that the number of cases is decreased a lot. And actually, we have we run at a certain time up to 5 ICUs dedicated to the COVID, and now we have 2, and in a while we will have just 1. Is a 16 beds unit, where we still have some of the patients admitted, not really at the very beginning, but we have really long run of respiratory failure. So, and basically, let's say in the last week, we admitted only 1 patient to the ICU.
Ah, okay, got it.
A COVID patient, let's say. We admitted several other kind of patient, but not that one.
So you had a run on EMS calls, as you and I have talked about last weekend, and after the announcement that people, in a way, were maybe worried and called and overwhelmed the system, and you set up a mechanism to take calls there by setting a strike team or whatever we want to call it over there that could get in the dispatch office and field many of the calls, and that helped prevent a rise in ambulance transports, if I remember. How is that working now? Are they still up and running, or is that standing down now?
Basically, the number of calls went down to the, let's say, usual numbers. We don't need anymore to have extra people dedicated to that. Let's say that we shut off the locking period March the 4th, May the 4th. So we are just not having any kind of increase in the number of calls up to now. We will see next days, but now we are prepared in how to deal with this problem.
Yes. So another question, and you may not know the answer to this, but I've been asking this same question over and over again, is this issue of the antibody testing. And your experience there is you've had people who turned antibody positive by ELISA, and yet later they were negative. So we think maybe the antibody testing is waxing and waning, and we don't even know if that affords you protection. Do you have any further thoughts on this? Because I know your people are looking at this.
Not yet. Right now, we are just collecting a lot of samples, and we are, let's say, for all the people in the hospital had been tested, so are 4,000 people inside the hospital, but we don't have so many repetitive samples, so I cannot tell you if how many did they change from negative to positive or from positive to negative.
Yes.
I cannot tell that.
And then I think just to thank you for being on board. I just can't, this is just, you're so busy and it's a Friday evening there, and I wish I could get you a night off. But one question I do have is that as you probably saw on the Eagles chat or emails, we were talking about prone positioning and different positionings. I think most people are finding that if you actually rotate positions, it could be not just prone, but maybe to the lateral sides, or I don't know if you want to call it like a rotisserie approach or whatever. Did you find the same thing was useful to you, and you just experimented and found out what was best for the patient, or how did you approach that?
I must confess that we used the prone position even as an advice to the people who, for example, in some area of Italy, we had the troubles in admitting patients to the hospital. So yes, it was an advice that the EMS system gave to patients at home. So just we told them to move to the prone position. But besides that, we saw basically a really nice effect in all the patients we admitted to the ward. Besides the fact that the effect of the patient intubated, but on spontaneous ventilation, on CPAP, they had basically a quite consistent improvement in oxygenation.
And just so that the rest of the folks on the phone or on the webinar here know, is that you guys really were the first ones to do that in the Milano area, 20 years ago, I think, maybe for ARDS. So you really, gave us a heads up on that, so to speak. I appreciate it. So any other thing you want to communicate to us before we move on to the next person?
It's just, I thank you all for the chance you give us to share the experience with you.
Yeah, it's good. Hey, and I'm also waiting for the information from your colleague, so I can finish off that thing for you. Okay, so thank you so much.
Thank you.
It was a privilege talking to you always. But stay on the phone if you can, if you'd like, and it's great to have you on board with us. So let me take advantage of this time now to talk to a couple people we haven't talked to for a while. One person I think would be good to hear from is Paul Banerjee. Paul has been one of our people who've done some really dramatic work this past year in terms of cardiac arrest for children, and he's been the innovator of the year for for EMS Today and various other things, and just been a good leader for down in Polk County, Florida. And Paul, thank you for joining us. I just want to know, is there anything new happening in your realm, particularly in the area of cardiac arrest for children, or anything else you could report on at this point in time?
Well, I think,
let me interrupt you just for a second, is that one thing that he did was we showed that the whole scoop and run approach we used to use with kids basically was pretty ineffective, and by working them right away as soon as possible, he was able to bring back a significant amount of other people, particularly if you code for ventilation, because it's a cardiac arrest state at that point in time. But go ahead, Paul.
Yeah, that's obviously a big thanks to Paul and Peter Antevi as well. So from a arrest point of view, our numbers are down, but from a COVID point of view, we got part of the CARES grant. We have about $30 million that we're going to use. Antibody testing, we're going to do approximately, we're going to test all the family and crew for Polk County Fire Rescue, all the sheriff's office, all the county commissioner office, all the municipalities and police, sheriff, everybody else. And then we're going to retest our antibodies on our crews at 1 month, 2 months, and then 6 months to see if there's any antibody prevalence that's continuing with our crews. With the other pot of money that we have, we're going to allocate the hospitals, and they're going to do free antigen testing for the citizens, and they can sign up on a website and log on. About 10,000 test kits per hospital that we have, and the hospitals will test people as a first come, first served basis. We're to get all this, collect this data. Approximately 150,000 tests will be done, and then we're going to simulate it. And hopefully you'll get involved in that research with us, Paul, and we can publish something that's hopefully gives some information to everybody.
Okay, terrific. Okay, and then by the way, just so you know, Polk County, Florida is just a little bit south and west of Orlando, and it's a large territory there. And you've just done a great job down there. So thanks a lot for being. When I saw you on the line, I wanted to bring you in if you didn't mind, because you've been monitoring this. Another person, I don't know, Scott Nichols, I don't know if there's anything you want to report on from your end. I happen to see you there because that's another aspect of things. Scott is been responsible for monitoring mass gatherings, and I think that over the years, and many have probably met him as we've gone through various cities. And Scott, is there anything to report on from your end or anything of note, except for the fact that there aren't any mass gatherings, or are we hearing that maybe they're starting to open up? For example, I'm hearing about that possibly down in Australia, for example.
Yeah, Paul, well, thanks for having me on. Real quickly, I think on our side, everybody's preparing for various states to be reopened based on what the mayor and each of the governors are going to be allowed to do. But obviously, the industry as a whole is looking at different ways to safely open. A lot of the buildings around the globe here are seeing first how they're going to safely bring their 1,500 people back to work safely for some stadiums. So a lot of that is currently going on. So preparations on PPE for these buildings are on the forefront. And we kind of are teaming up with a technology firm that has a corner with Google and I believe Apple of a COVID tracking system that they're utilizing through their mesh web technology with an app. So we're going to be bringing that to the forefront, and that's something maybe I'll on our meeting that we got this evening, I'll kind of bring you up to speed on that and what's happening. But some really good stuff that is going to help track and isolate. And there's some more political things that have to kind of be guarded for HIPAA regulations and things of that nature with technology. But it's some good stuff that is going to probably open up a lot of opportunities to at least track this thing.
And I think I think part of it is that local folks here that run the EMS systems may not necessarily be covering the stadium or the arenas directly, but they may have to interface with you, especially if people are waiting outside there for quite a while. So it'll be interesting to see, you know, how that interface is going to go. And but you guys are coordinating also with local, you know, public safety officers as well, correct?
Yeah, fire department, all the health and safety that's going to be affiliated with that county and township. It's going to be obviously a joint operations with all hands on deck when buildings start moving things, when NFL gets their stuff sorted out. The baseball league, they are handpicking 3 locations to have the teams play in 3 states and get everybody on board there to try to isolate it. The things that are currently missing is that any sports teams that do open up, there is going to be a collections of those folks in the township that want to be part of the buzz and just showing up at the venue. So there's some planning and preparation that they're going to have to think through once they do start playing these games.
So even if they're not in the stands, there will be people that will show up, and that may affect us in EMS and public safety.
Yeah, in the community. So they'll want to get a glimpse of the sports teams coming from the hotels to the venue, and then waiting around as the game's played to catch a glimpse. And in the market, if you're not having a show or an event, you are still going to attract the small percentage of that volume coming to that location. So if you've got a stadium that usually has 35,000, you might get 1% to 2%, 3% just hanging out around the outside of the perimeter. So
Yeah.
law enforcement, fire department, everybody's going to have to contend with the stagnant crowd.
Yes. Okay. Interesting then. And since they're outside, they're probably exposed to elements and all that, so it may have an impact. And either they'll get snow if they're in New Hampshire tonight, or 88 degrees in California, right? All right, that's great. Anything else you can add, Scott? Has this been useful for you, by the way, hearing in what's going on worldwide here?
Well, everything's good because it opens up the door on what the medical community is and their individual challenges that they got to face, and then the economic pushback that everybody feels and how it hampers our first responders. So what this does is kind of help me bring some information to others that are trying to have some solutions through technology and coordination that I can bring back to the table for you to present to see. I think more frames of references, the better everybody's going to do to draw upon.
Yeah, fantastic then. Okay, so let me now, if you don't mind, I'm going to jump over to Meg Marino in NOLA, New Orleans. And Meg, you guys got hit hard. Are things calming down now? What's happening with your force, your workforce, and what's happening with you, and what's happening in the Bayou City there? Oh, not the Bayou City. What am I talking about? The Crescent City. Sorry about that. Meg, are you there?
Oh,
Can't hear you very well.
I'm here. Can you hear me?
Yeah, now we can hear you. Yes, go ahead, please.
Okay, great. So thanks so much for having me. We're doing great in New Orleans. We've been working hard to try to kind of put things back together as our counts have been going down. We're still under a stay-at-home order right now, which has we're anticipating that it's going to be lifted next week on the 15th. So we're hoping that we don't see a second wave. But for now, we've been seeing a decrease in the number of new cases that we're seeing. We have room in our hospitals and emergency rooms and ICUs. We only have 12 employees right now who are out sick, which is down from 35. Wow. Which is really exciting. And we've been really focusing on mental health and kind of how to bring everybody together right now, because things have been hard these last several months. So we're really grateful for all of the support from this group. The next thing that we're looking at is maybe some antibody testing to see how that will help us make decisions moving forward, or if it will help us make decisions moving forward. But we're really excited to see what will happen next.
Okay, are you able to get beignets yet?
No, Cafe du Monde is still closed.
Okay.
But today, my favorite morning bakery opened up, so I'm going to go over there and get some cupcakes a little bit later.
And you have a good, you could double up on your N95, right? For me, make sure.
Yes.
Okay.
Yes, I will.
Help you. Thank you so much. Anything new on the pediatric front that we can beyond what you reported previously?
No, I think the big thing that's come to light is this Kawasaki-like syndrome that we were talking about before today. Yeah. And I think it'll be really interesting to see what happens over the next few months and seeing what the data shows with that. But it's been very interesting and scary as well.
Yeah. Okay. So the next thing I want to do is that maybe jump out over, get out of Oconus, the outside of continental U.S., and talk to Sean Covant from Honolulu. If you don't mind, Sean, if you can get on and tell us. And then later, just be prepared. I'm going to then maybe talk to Dustin Calhoun, okay? And so go ahead. And then John Ju, I'll be picking up with you pretty soon. Go ahead. Are you there, Sean Covant from Honolulu?
Aloha, Paul. Aloha, everyone. Thank you for having me. So we're doing well here in Hawaii. We've been tracking our cardiac arrest, Paul, and we haven't seen a large uptake yet, which is sort of reassuring. What we have seen is a slight increase in our DOAs, which we think might be secondary to a lack of calls. We did a really good job of messaging to everyone to sort of stay home and call when only needed. And I think that was interpreted in that a lot of people have not been calling when they should have. So similar to Europe, we've been sort of readjusting our messaging as to how we can sort of reopen slowly and get that DOA rate down a little bit more. As far as volume goes, EMS volume is still down, slightly increasing, but still down year to year, as well as in the hospitals. And our big thing is that we're trying to figure out how to reintegrate our tourism into the.
Oh, yeah.
Yeah, because we're in an island in the middle of the ocean, that's a geographic advantage as far as the COVID part goes. So they're just trying to debate on whether there's pre-screening will be required for people to fly to Hawaii. So just stay tuned on that matter.
Yeah. Okay. And then, so the next question I have is, where do you prefer to get your malasadas? That's what I know.
That is a real struggle. We import a lot of the basic ingredients, so there have been small fights for that. So it's a secret we will try to hide.
Okay, we'll keep that to you. But thanks for joining us, and really appreciate you coming on. Next time we want to see your face, so make sure you plug on that way. Libby, while we're there, Libby Char, who's been our long-standing participant from the islands, Hawaii. Libby, anything to add to you, and anything else you can share with us?
Hey, Paula, it's Sean again. I know she said she had another VTC she had to go to. So
Oh, okay, no problem then. I just wanted to make sure that you know, that we had included her. That's all, since I was out there. Then Dustin, let me go ahead and see what's happening over in Indianapolis. Okay, what's happening on your end of the world? You there?
Yes, sir. Yeah, Paul. In Cincinnati here, we re-looked at our cardiac arrest data and found that, unlike a lot of folks, we haven't seen much increase. If you're really looking just at what we're reporting into CARES, we're not seeing an increase, which I found kind of interesting when I looked at what Dr. Augustine had put out with regard to Dayton. So we started looking some more, and what we found was some of it was the way things were being coded. That didn't matter for some previous analyses we did, but it mattered for this. So our left on scene, our DOAs actually have increased, and we're working on trying to refine exactly what those numbers are. But we aren't seeing nearly the increase some folks are, but we are seeing some. The other big issues we're having here are, like a lot of folks, with our congregate care living, or specifically our nursing folks. Great thanks to Ken Chemke from the stuff that he sent me from what they were doing. Unfortunately, our state, in particular our region, has not been nearly as forward-thinking as their area was. So we're still a little bit behind the curve on that, trying to catch up. One of the biggest issues we've had there is actually trying to load balance from nursing homes. We had a nursing home the other day that had about 2 nursing homes combined in one hospital's area, had about 15 cases all in one day get discovered, all got transported to one hospital for a questionable reason. And we're now working, we did a lot of work with load balancing between hospitals. We're now trying to work with some load balancing and trying to manage where those patients are going rather than overwhelming single hospitals. But those are some of the biggest issues we're dealing with here. I'm sure very similar to what everybody else is. And great thanks to this group, because a lot of the stuff we're catching here is getting applied, unfortunately, a little bit retroactively, but still great help here in Cincinnati. So thank you.
That's great. Hey, and Ben West, I'm going to pick on you next from Milwaukee. Just wanted to see, because it's interesting, because you're a city that was supposed to have a national convention. I think were the Democrats coming there to your area, and is that off now? And what's going on in terms of that issue?
Yeah, hey, Paul and everyone. So the DNC is still planning on moving forward. If you ask the Secret Service, they say they are a mission-based organization, and they've been given the mission to host the DNC. So they're moving forward. I think the DNCC that's organizing it is working to change the format a little bit to be more infectious disease oriented, but they're continuing to watch the situation and hoping it improves. I'm not sure it'll improve too much by August, but that's what they're hoping, and they're moving forward with planning. I think they're going to probably end up having sort of different levels depending. So you have your full convention, you have your very minimal virtual convention, and then you have a lot of areas in between. So that's what we're kind of working through right now, but it'll be interesting to see what happens.
Okay, good. And then you have a large African-American population in Milwaukee, and then did you get hit a little hard on that, say, compared to the rest of the state, or has it been about the same across the state? What do you think?
Yeah, no, there's been 3 counties in the state that have been hit hard. Milwaukee County, far and away the worst. Dane County, where Madison is, I don't know if Megan's on right now, was hit relatively hard. And then Brown County, which is where Green Bay has had a big outbreak in one of their, I think it was a meat packing plant. But Milwaukee County's been hit pretty hard. The African American population much harder than the rest of the population in Milwaukee County for sure, both cases and deaths.
Okay, and then and has EMS stayed busy with that, or is it just mostly the hospitals at this point?
You know, honestly, EMS and hospital volumes have been a touch down.
Okay.
It's been up for COVID, obviously, but I think a lot of us had a similar experience where everything else is just down. I think fear of engaging the hospital system, as well as canceling all the electeds and everything like that.
Okay, great. Thank you so much, and stay in touch, okay? And then
thank you.
Let's just move over to Washington, D.C. briefly to see if there's anything new in our nation's capital, okay? Rob Holman's there. Hopefully he can get on. If he's not, he's usually engaged with other things at the same time.
I'm here. I don't know if you can see me. I couldn't get it to visualize.
Can't see you, but that's, you know, probably sparing some of us, right? So that's it.
Thank you for that. That really generous.
We love seeing you. You know that.
So,
okay.
Everything here is happening just like it is everywhere else. What's interesting is that I've been asked to serve on the Reopen DC advisory group for the mayor.
Yeah.
We're following the gating criteria as posted by the White House document, and we're nowhere near opening. We have, in terms of, you have to have actually a decrease in your ILI, your influenza-like illnesses. New Jersey is the highest, but Maryland and the District of Columbia are still the other jurisdictions that are in the high group. So that's a disqualifier. The number of cases continues to climb. Yesterday was the highest, 193. And then also our proportion of the testing that is resulted as positive is still high. It hasn't come down. It's about just shy of 22%. And then we're having, we built a surge center for 500 beds. It's going to open on Monday at our convention center. And we don't know whether we'll use it, but one of the biggest hospital has 83% of its ICU beds that are full. So that's where we are.
Okay, well, thanks for the report. Really appreciate it. I do want to go to, where was I? I just wanted to go to, I just remember. I'll try to figure it out here real quick. I think it was Joe Holly. That's right, because I hadn't heard from Joe for a while. How's Memphis doing, Joe? What's going on there? And then John Jew, I'm going to hit you up next.
Hi, Paul. Memphis is still in our slow, steady increase in numbers. We began reopening the city this Monday, so we expect another week or so before we start really see significant changes. But slow and steady, preparations are doing okay.
Okay, good. Okay, so nothing really major to report, but thank you for just being there and really appreciate it. I hope this has been helpful to you on this line.
Absolutely.
Let's go to Portland. John Jew, what's happening out in your neck of the woods, and anything we need to know about on the infectious disease since you monitor that pretty close? You and Rob both do.
Yeah, Portland actually is doing quite well. We're actually probably going to open up the rural aspects, Eastern Oregon, the end of this week. Portland, our hospitals we show a clear trend going down, and our governor, along with Governor Inslee in Washington, are coordinating very closely, as well as in California. So we're going to do a controlled opening. We'll have to see how we really do. I'm cautiously optimistic. The other one is, like, I worked 2 shifts this weekend, and they were normal shifts. Our EMS volume is back to normal, and people are starting to move around as well. So, so we expect some spike here as well. Other than that, we're watching the antibody closely. I expect validation of some sort of antibody, which ones we can trust, in probably 2 months or so, depending upon who the manufacturer is. But I think that's going to settle out in 4 to 8 weeks. Then we can actually start going forward on that as well.
And John, a big question that has been raised, like by Ken Shepke several weeks ago, was that a lot of these antibody tests may have been cross-reactive with other coronaviruses or previous SARS viruses, because that was the platforms were based on that. And so what I wanted to find out was, do you know if these new ones, like say the Roche one or the Abbott ones that are coming out, are they very specific for COVID-19? Do you know that for a fact?
Well, I can only repeat what the manufacturers say, but both the Roche and the Abbott tests are do not cross-react almost zero as well. So they're actually looking for the cross-reaction here as well. The other problem that occurs is that first of all, the presence of antibody does not mean that you're actually protected. It means that you've been exposed. So if you're looking at the nucleocapsid, that's probably the best target for the antibody as far as exposure. And the spike protein, the two components to that will give you probably as correlates well with the neutralization and the protection capability.
Yeah. Okay, so this remains to be seen, but maybe we're going to make some progress on that. And in the meantime, be very wary about whatever the antibody means. Even if you test positive, no matter what the kit is, even if it was absolutely specific, we don't know what it means in terms of protection. So don't think that you are immune at that point in time, at least. Right?
Yeah, I always expect anybody on this call to do your homework and research the antibody and what you're really trying to test.
Yeah. So anyways, we will do that, and we'll be turning to you, of course, to give us some guidance on that as time moves on. Thank you as usual, John. I really appreciate it. Hey, Veer, I'm going to probably call on you here over there in Fort Worth. You ready to go?
Yeah.
Hey, so what's going on in Fort Worth?
So our big focus, like a lot of people, is our nursing homes. We stood up some strike teams, partly with the state and partly our FRO fire department hazmat unit stood up a testing team. They've basically been contracted with our public health department, who don't have the resources to do testing, and they're working on testing every long-term care facility that has essentially a first case. That's been our biggest initiative so far. Those are where almost all of our clusters of patients are. And then we've been trying to work with the jail and prison population too. We made the news for the federal prison and the amount of cases and deaths that we've had there. Unfortunately, I had a meeting with them yesterday, and they basically just said, "Oh, we got it under control." At least we try to offer, but that's our big thing right now. Lots of testing, and that's about it.
Okay, thank you so much then for what you're doing over there. And then David, let's just move down the highway a little bit further to David Miramontes down there. And what's happening? Anything new in San Antonio? You guys have been doing a great job down there. Anything new that I should know about?
Yeah, so we're opening up today, barbershop, salons, and all other kind of stupid ideas, but including flea markets, actually, because they were determined by the governor to be a reopened business. So we are really ramping up testing here. We have deployed teams for walk-up testing at some of our more socio-disadvantaged areas, and where we have a lot more people of color that haven't been tested very well with our current model. We have a state tasker to do congregate setting testing. So we've been doing the jail, we've been doing nursing homes, we've been doing, and actually our teams are going outside of San Antonio on some of the state missions. So that's been ramping up. So it's all about testing. It's all about monitoring as we probably prematurely open up a lot of the restrictions, unfortunately. Locally, we really didn't want to open up yet because we're not ready. But unfortunately, it's a state mandate, so we have to go with the flow and just mitigate the harm that may cause in the near future so that potentially we could shut back down again. Our call volume for COVID is actually going down, which is good. Our hospitals are doing really well. Right now, our capacity is good. Most of our hospital systems have rapid testing in-house. And their big driver that had nothing to do with the pandemic, but rather what it did, the driver of that was so they can do outpatient testing, cath lab stuff, elective surgeries, colonoscopy, all those types of outpatient radiology stuff. So all of our hospital systems now have some form of very rapid testing to screen those patients as like Dr. Matu was talking about for cath lab stuff. So all of our hospital systems are very anxious to get back in the business of medicine, taking care of some of the stuff that's been neglected for the last couple months. But other than that, we've doing well with PPE. We have the Patel system here, so we're getting that started so that we can use our N95 masks in other type situations over and over again. So we're using an APR with replaceable cartridges every 2 weeks, and that's been really effective for us. But we're really concerned about dentists, primary care clinics, physical therapy, rehab facilities, nursing homes, etc. So thank goodness we got the Patel system located in our area that can help decontaminate those N95s for reuse up to 20 times.
Yeah.
So those are the big things that we're up to here in San Antonio.
Thank you so much, as usual, for everything you do. You guys are so far ahead of the curve. All that, and then later, when I see CJ on the phone next time, we got to congratulate him for that great publication he had in the international, textbook on the blood work you guys have been doing down there. So we'll do that later, okay? So.
Yep, and surprisingly, we're still giving a lot of blood. It's like 19, 20 doses a month, and that hasn't changed through COVID. So
Fantastic.
even though
any you want to give us a preview, or not ready for prime time yet in terms of that you think you're making a difference is in improving outcomes?
Not ready for prime time. That has to be officially released. Sorry.
Sure, no problem. That's what I thought. Okay, let me. We've heard from Tom Collins before from Cleveland earlier, I think, in the week. But anything new, Tom, to report, or anything we can follow up with you for or answer for you? Oops, I don't know if Tom heard us. Tom Collins from Cleveland. Maybe he signed off as well. So okay.
Hey, Paul, it's Tom.
Yeah, go ahead, Tom.
Yep, sorry about that.
No
Having a little trouble with the mouse.
Yeah.
No, I think we're gonna have some interesting data out of our longitudinal serology study of our medics. We'll probably be able to share with everybody in about 2 weeks.
Okay.
Things are settling down from the COVID side, like everybody else. The skilled nursing facilities are bad. We have one with 90 patients in it right now.
Okay.
Causing some trouble. So
we'll give me a heads up when you're ready to report the information. Of what your testing has been doing, so I can make sure I put you on the schedule to talk.
Will do.
Okay.
Yep.
Hey, Lakshmi, anything else you want to add from Atlanta? Sorry you got cut off before, but sorry that's raining there, right?
Yeah, it's drizzling. Sorry about that. No, I was just saying that we haven't quite seen the numbers that Jim Augustine was talking about, and that might be a Georgia thing. We are counting our cardiac arrest based on who resuscitation is initiated on. So we're not counting the people that are dead when we get there. So it depends on what we're comparing. And I know there are certain pockets in Georgia, especially the rural counties, where they've seen a huge incidence. So some of those numbers might be secondary to that too. Our cardiac arrest numbers in the city have not gone up by much, thankfully. But the rest of it, the overall numbers are definitely lower than baseline, but we're slowly catching up now that the city is opening.
Okay, fantastic then. Thanks for keeping us up to date on that. I see we have the Florida contingent on there. I don't know if the people like Ken Shepke is there or anybody else who wants to give any report from the Florida area before I sign everybody off here.
Hey, Paul, I'm not sure if Ken is on, but the report here is that we have 2 IRBs that have just been approved this week. And we're launching our first validation. We're going to be validating the CellX antibody test tomorrow for the company. And then we're launching a longitudinal study, which is going to look at 3 cities over a 12-week period. We'll be testing all city employees 3 times, day 1, 6 weeks, and 12 weeks. It's been signed off by the Surgeon General. And we're excited, and thank you for all your help with all of that, Paul, and to the other investigators as well. But we're excited about it.
Okay. Last thing I want to leave with everybody with is that unfortunately, there are other countries that are starting to get overwhelmed, including Brazil, Mexico, and so that may be something to tell us about what we may have to worry about in terms of resurgences in different ways worldwide. We'll just see how that transpires, but it's kind of unfortunate, and it is moving around the globe in a very, non-heterogeneous, in a heterogeneous, non-homogeneous manner. So it's, I think, as we've talked about before, this is going to be going on for a while. All right. Anybody else want to pipe in and say anything in particular before we part? Any other news report or any other comments to make or any requests of us?
Hey, Paul, will you
Yes.
keep us on track, because you're the international guy, with what's happening in Brazil and South America and the other Southern Hemisphere places as we go?
Yeah, I will do that, and maybe next time I'll give you a kind of report. And that's what I'm saying is it's not looking good, and I'll know more by next week because things are just starting to get reported about how bad it is there. I was told by my counterparts down there 3 weeks ago that it was going to be that way because to be very blunt, what I heard was that the government wasn't taking it very seriously, and now we're seeing what's happening there. So, all right. All right, well, with that, it's looking like it's not quite 1 o'clock on the East Coast or noon on the Central and so on, and it's time, I think, to go ahead and depart. Thank you, everybody, very much. Welcome back again on Tuesday. Welcome back, my friends, to the show that never ends, and thank you again for participation here. Appreciate it. Okay, good day to you. And happy Mother's Day to the mothers out there, okay? So see you later.
Thanks, Paul. Bye, everybody. Have a good one.
Thank you.
Thank you.